Hi, this is Andrea Kane, and I'm here with you for HIT 330, Delivering Healthcare in America. This is Chapter 1 for Week 1, an overview of the U.S. healthcare delivery system. Our learning objectives, according to the textbook, are to understand the nature of the U.S. healthcare system, outline the key functional components of a healthcare delivery system, get a basic overview of the Affordable Care Act, discuss characteristics of the U.S. healthcare system, emphasize importance for practitioners and managers to understand the healthcare delivery system, get an overview of healthcare systems in selected countries, point out global health challenges and reform efforts, and introduce the systems model as a framework, which we'll use to study subsequent chapters and pieces of the healthcare delivery system over the rest of the semester. So the U.S. has a unique healthcare delivery system. Americans are not automatically covered. A true system does not exist. The healthcare system is fragmented, and it continues to undergo periodic changes. The healthcare workforce employs over 16.4 million people, and you can see here that's over 838,000 active physicians. In addition, 70,480 doctors of osteopathy, 2.6 million nurses, 5,795 hospitals, 15,700 nursing homes, 1,375 health centers, 180 medical and osteopathic schools of medicine, and 1,500 plus nursing programs. And then there's so much more beyond that. But this is just a snapshot of pieces of the healthcare workforce and those who are involved with it. Some characteristics of the U.S. system include multiplicity of financial arrangements, numerous insurance agencies and managed care organizations that employ various mechanisms for insuring against risk, multiple payers that make their own determinations about the cost for each service, diverse settings where services are delivered, numerous consulting firms offering expertise in planning, cost containment, electronic systems, quality, and restructuring of resources. There is little standardization and sometimes missing dimensions in system in terms of planning, direction, coordination from a central agency. This causes inefficiencies to be created, including duplication, overlap, inadequacy, inconsistency, and waste. There are attempts at cost control using financial manipulation, and although there are two primary objectives, they are not always achieved, and that is enable citizens to obtain needed healthcare services and ensure cost-effective services and meet quality standards. There is emergent care available for those who have something significant happen to them through emergency department care. But beyond that, there are various mechanisms that are trying to be put into place to provide citizens to obtain needed healthcare services, but there are lots of barriers and challenges with that, and that's where telehealth can be a help, in addition to some others. So we'll be studying all of this, not just this week one, but as we go throughout the program. The U.S. leads the world in medical technology, medical training, research, and sophisticated institutions, products, and processes. But having said that, our quality and costs are often challenging. So let's talk about financing and insurance mechanisms. We have employer-based health insurance, which is private. We have privately purchased health insurance, again, private. We also have government programs, which are public. Those include state employees groups, Medicare, Medicaid, and CHIP. And CHIP has to do with Children's Health Insurance Program. These cover federal and state employees, elderly and certain disabled people, indigent, the poor if they meet eligibility criteria, and some children. Medicare, Medicaid, and CHIP have been targets of healthcare reform before and will continue to be because they are government programs. Reasons why employment-based system has left some uninsured include small businesses that cannot get group insurance at affordable rates and are unable to offer insurance, as well as participation in insurance programs may be voluntary and employees may choose to opt out. The Affordable Care Act required all U.S. citizens and legal residents to be covered by public or private insurance. There are some pieces of the Affordable Care Act that have been repealed or struck down through courts, and there are some pieces of the Affordable Care Act that remain in place, and that makes it a little complex as we go forward studying this topic. When we look at the characteristics of the U.S. healthcare system, these are things that we need to keep in mind. The political climate, economic development, technological progress, social and cultural values, physical environment, population characteristics, which include demographics and health trends, as well as global influences. This is a really good graphic that shows you all of the different external forces that are affecting healthcare delivery. And I'm not going to read through those. I'm going to let you go ahead and do that. There are 10 basic characteristics that differentiate the U.S. healthcare delivery system, and these are: 1, there is no central agency that governs the system. 2, access to healthcare services is selectively based on insurance coverage. Healthcare is delivered under imperfect market conditions. Third-party insurers act as intermediaries between the financing and delivery functions. The existence of multiple payers makes the system cumbersome. The balance of power among players prevents any single entity from dominating the system. Legal risks influence practice behavior of physicians. Development of new technology creates an automatic demand for its use. New service settings have evolved along the continuum. And number 10, quality is not accepted as an unachievable goal. So let's break each of these 10 down. Number 1, no central agency. Most developed nations have national health care of one form or another. To control costs, they use global budgets to determine total healthcare expenses. The government controls the proliferation of health services. Whereas the U.S. has mostly private financing and delivery. Financing via employers is 52% and the government is 48%. Private healthcare, hospitals, and physicians are independent of the government. No one monitors total expenses through global budgets and utilization as they do in countries that have national healthcare systems. The U.S. determines public sector expenses and reimbursement rates for Medicare, Medicaid, and CHIP. The government sets standards of participation, and these are called COPs, or conditions of participation, but they have to be met to be certified to provide care for Medicare and Medicaid patients. And these standards, or conditions of participation, COPs, are regarded as minimum standards of quality, and trust me, they really are minimum when you get down to it. Talking about number 2, partial access. Access is the ability to obtain health care when needed. Americans can access health care services through their employers, under a government health care program, by buying insurance using private funds, by paying for services privately or self-pay, by obtaining charity or subsidized care. Health insurance helps ensure access. Uninsured Americans are able to obtain medical care for acute illness. They usually have some form of universal catastrophic health insurance, but they often forego basic and routine care. Universal access occurs in countries with national health care programs providing universal coverage. The ability of all citizens to obtain health care when needed is mostly a theoretical concept, so please keep that in mind. Even in countries that do have universal access, they do limit health care. Sometimes their citizens have to wait for health care. Sometimes, if their prognosis is grave, they may be denied treatments and resources that may be used on others who have a better prognosis. Number 3, imperfect market. The U.S. has a quasi-market where healthcare is partially managed by free markets. Notice that, partially managed. In a free market, multiple patients and providers act independently. So we're not a true free market here in the U.S., but in a free market, this is what would happen. Providers do not collude to fix prices. Prices would be set by the interaction of supply and demand, An inverse relationship between quantity of services demanded and price of services would exist, and equilibrium would be achieved without interference. There would be unrestrained competition, and patients need to have information about the availability of different services. That is happening, but it's still not completely where it should be if we were a perfect market. Consumers are seizing some measure of control by looking at cost, looking at quality, but they're still a long way from seizing more than just a little measure of control. The internet is a source of medical information, but as we all know, the internet is not a perfect source of information as there is misinformation out there. Patients must bear the cost of services received, and there is such a thing as moral hazard. Continuing with imperfect market, there are two factors that limit patients' decisions that include need and demand. There is item-based pricing, where you have fees charged for the service, like a surgeon's price. There are phantom providers, where you receive a bill for services separately. A good example of this is if you go to the emergency department, you'll get a bill from the hospital that owns the emergency department for facility services, but you'll also get a bill from the ED physicians group for the physician services, or the PA or the nurse practitioner, whoever it was that treated you. Then there is package pricing. There are some cases where a bundled fee for a group of related services is how it is paid or priced. Number 4, third-party insurers and payers. Patient is the first party. If you're talking about parties, patient is the first party, provider is the second party, the intermediary or payer is the third party. It is a wall of separation between financing and delivery. Quality of care is almost always a secondary concern because this is about financing and delivery, not necessarily the quality. In a single payer system, such as a national healthcare system, they're usually the primary payer, the government. The United States has many payers. The company can choose different plans, which creates a billing and collection nightmare. Having worked in that world, it truly is. Each payer has their own policies and procedures. Each payer approaches things differently and wants you to approach things the way they want you to approach them, and it can be a real headache. Multiple payers, the system becomes more cumbersome. It's difficult for providers to track various health plans. Providers must hire claims processors. Payments can be denied for not following requirements, which necessitate rebilling, which is rework, and that delays the amount of time before you get your reimbursement back. Some plans do allow providers to balance bill, whereas others do not. Providers must engage in collection efforts, and the government programs do have very complex regulations which change over time, so you constantly have to be aware of what the payers are requiring, what changes they're requiring, and the government is no different. Power balancing, you have multiple players. These key players include physicians, administrators, insurance companies, large employers, and the government. Each have their own economic interests to protect, and that often keeps them from working together to fix the system. Self-interests are often at odds, and the patient is not necessarily, again, the center of all of this. Although we'd like to think so, although our politicians and others tell us that everything should be patient-centered, the truth is all of these groups have their own economic interests, and their self-interests usually come first. Litigation risks. The United States is a very litigious society. Private healthcare providers are increasingly susceptible to being sued and having to settle, even if they did nothing wrong. Having lived in that world and been a part of it, I can tell you that for certain. Because of the risk of medical malpractice lawsuits, most providers practice defensive medicine. They have to. They order and prescribe diagnostic tests, return checkups, do additional documentation. A lot of times it's really not necessary, but it has to be done in order for them to protect themselves. The amount of money that's spent on medical malpractice insurance payments by healthcare providers and healthcare organizations is absolutely sickening. And tort reform is needed, desperately needed in this country. But until that occurs, until there is actual tort reform and we get some of these malpractice lawsuit situations in hand as a nation, this will continue to be a way that resources, time, energy, effort is wasted. High technology. The U.S. is a hotbed of research and innovation in new technology. They create demand for new services despite high costs. And with capital investments, you have to have utilization of that technology in order to pay it off. Legal risks for providers denying new technology have occurred. So we keep innovating, bringing new technology to the world. That creates a demand. You see a lot of people who can afford it coming from other countries who have national healthcare systems to the U.S. to get care, get that new technology that's not available to them in their own countries. And you'll see that there's a demand between the organizations, the healthcare organizations, where there's competition to make sure that they have that technology in order to differentiate themselves from their competitors. It's not enough to have that technology. You've invested millions of dollars. Now you need the patients to come. You need the payers to step on board and pay for the new technology. And sometimes when payers refuse to pay for the new technology, you get some issues that happen with that. Number 9 is continuum of services. There are 3 categories of medical care services: curative, restorative, and preventative. Healthcare is not confined to the hospital anymore. Traditionally it was. In the last 25 to 35 years, that has changed dramatically. There are now additional settings. This graphic shows you types of health services and the different delivery settings that you might see that occur in. This is in your book, and it may be easier to read there. Number 10, quest for quality. Definition and measurements are not clear-cut. It would be so much easier if they were. There's increased pressure to develop quality standards and to demonstrate compliance with them. That creates higher expectations of caregivers, organizations, even patients at times, and continuous quality improvement needs to occur. One of the challenges with the U.S. healthcare system is, yes, we have all this innovation and new technology. Yes, we have all of these settings and continuums and opportunities, but we're not consistent in providing top quality care. There's a lot of variation. There's a lot of resistance still in the healthcare industry to choose true quality indicators that have been peer-reviewed and proven over time and use them. And think about it, all these medical schools train their medical students differently. They don't use the same quality measures in training physicians. And if you don't do that, you're gonna get all this variation, which brings high and low quality to the table, high and low cost to the table, long and short stays, lengths of stay in settings to the table. So until that is dealt with, we're going to continue to see some of these challenges when it comes to quality. And unfortunately, many of them cost patients their lives. This is trends and direction in healthcare delivery. We're moving away from focusing on illness to trying to stress wellness and wellness activities to prevent illness. We're moving away from acute care and hospital-based settings to primary care and outpatient settings. Again, we're moving away from inpatient to outpatient, away from looking at individual health, although we still are doing that and seeking out ways on a genetic level where cures could be developed, to being more community well-being based or population health. You may have heard that term. That's becoming a real buzzword. Moving away from fragmented care to managed care, moving away from independent institutions to integrated systems, moving away from service duplication to a continuum of services. So trends and directions, the U.S. healthcare delivery system continues to undergo fundamental shifts. Promotion of health while reducing costs. Focus is changing from illness to wellness, providing more effective and efficient quality care, focused more on delivery of services, utilizing mid-level health professionals like nurse practitioners, physician assistants, certified nurse midwives, health coaches, and health information technology information systems. Some challenges that the U.S. faces is always managing costs, focusing on care delivery, adopting technologies, delivering new operating models, and meeting various federal and state regulations which change. Significance for healthcare practitioners. Why do healthcare practitioners need to understand the healthcare delivery system? It's so they can attune to their relationship with the rest of the healthcare environment, help understand changes and the impact of those changes on their practice, and so at the end of the day, they're adapting and relearning. Why do health services managers or health administrators or healthcare leaders need to know about this? Well, first of all, they need to position their organizations to survive and thrive. They need to know their organization's position in the macro environment, handle threats and opportunities, proactively deal with any threats to their institution's profitability and viability, as well as evaluate implications and understand relevant issues. They also need to be good at planning, strategic planning, which services should be added or discontinued, how to capture new markets, know emerging trends before the market is overcrowded, know what their market share is. Is that market share increasing, decreasing? What about their competition? What new technology or new services or new opportunities are coming so that they can advance their market? Also, complying with regulations is a constant challenge, and following their organizational mission to serve their community. All right, let's stop and look at the healthcare systems of other countries. There are three basic models. There's a national health insurance model, a national health system model, and a socialized health insurance model. Under the national health insurance model, you'll see that there's a quad functioning model that includes financing, insurance, payment, and delivery. So let's start with Australia. Australia switched from a universal national healthcare program to a privately financed system. It's sort of a cross between what Great Britain has and what the United States has, if you think about it. Their national program is called Medicare. The philosophy is everyone contributing to the cost of healthcare according to their capacity to pay. They have developed health service delivery models to contain costs and provide quality and accessible care. They've developed a national primary health care strategy. Again, they're really focusing on that primary health care. In Canada, they have their Medicare system that consists of 13 provincial and territorial health insurance plans sharing basic coverage. Nearly all Canadian provinces except Ontario have resorted to regionalization. Looks like 18 years ago almost, they created a 10-year plan to strengthen their healthcare system and transition to patient-centered care, and I believe that they're still working on that. In terms of China, keeping in mind China is a communist country, they evolved from a public insurance system or government or public enterprise to a multi-payer system. They continue to face the growing problems of a large uninsured population and healthcare cost inflation. They originally had a 3-tier referral system, but that's been largely abolished. Not much is known about China's healthcare system as they are very careful about what they reveal. They have said that they are doing health reform initiatives in health insurance, pharmaceuticals, primary care, public health, and public community hospitals. They said that they established an essential drug system and they have a plan. Not much is known about that. When it comes to Germany and the United Kingdom, they are a good portion of Europe, and typically other countries like to follow their lead. In Germany, they have health insurance mandatory for all citizens and permanent residents. They have passed a Pharmaceutical Market Reform Act and then an act to strengthen their SHI healthcare provision. The United Kingdom has what they call NHS, National Health Service. They also started a Better Care Fund in 2013, and they initiated a 5-year forward view plan in 2014. Let's look at Israel and Japan. In Israel, there is universal coverage based on the German SHI model, where there's an employer tax and individual income-based contributions. They also have implemented a national health information exchange. In Japan, they provide universal coverage with two main insurance schemes, employer-based and national insurance program. They have a primary care society and run training programs. In Singapore, they had a British-style NHS, National Health Service program, but now they have what's called Medisave, and that provides universal coverage. They've also worked very hard on their chronic disease management program. So, as we look toward the rest of the book, as well as the rest of the semester, what are we going to be doing? We're going to look at healthcare delivery through a systems framework. We're going to break it down and look at the system foundations. Then we'll tackle system resources. We'll follow through system processes, look at system outcomes, and then finish by trying to take a look in our fuzzy crystal balls about system outlooks for the future. So in summary, the U.S. has a unique healthcare delivery system when you compare it to the rest of the world. We use public and private financing. We use private health insurance and public insurance programs. We are not governed by free market principles. We should be, but we're not. No country has a perfect healthcare insurance system. I'm going to repeat that. No country has a perfect healthcare insurance system. It's not like we can say, oh, look at that country. They do it perfectly. Let's adopt it here in the United States. Every system has its challenges, its positives, its negatives. And so we have ours here in the United States, and that's what we're studying, but we want to be aware of what's out there in the rest of the world. Healthcare managers must understand how the healthcare delivery system works and evolves. And that is it for Chapter 1. I hope you have a fabulous week. I look forward to talking to you again soon. Take care.